Good evening, everybody. It is a great pleasure to me for me to introduce our first speaker today, who is going to talk to us about pitfalls in thyroid function test interpretation, this subject in which we should all be interested in our daily practice. So Dr. Elizabeth Pierce is a professor of medicine at Boston University School of Medicine in the section of endocrinology, diabetes, and nutrition. She was the 2018 till 19 president of the American Thyroid Association. She is regional coordinator for North America for Iodine Global Network, and she is deputy editor for Journal Clinical Endocrinology and Metabolism. Now, I will welcome you, Dr. Elizabeth, and the talk is yours. Please.
It's a pleasure to be with you. I want to discuss some of the pitfalls in the interpretation of thyroid function tests. And I want to start by thinking about cases where there are spurious results, that the thyroid function tests are just flat out wrong and we can't believe them. Think then about some clinical scenarios where there are alterations in thyroxine binding globulin and other binding globulins that can affect our interpretation of peripheral thyroid hormones. And then think about a couple of places where we can believe the test results, but the normal reference ranges may not apply. And then I'll finish by thinking about some of the places where clinical thyroidology actually gets really interesting, where there is discordance between the thyroid function tests, the TSH doesn't match up with peripheral hormone, and how we tease apart the rare clinical scenarios which can actually cause this from, the likelihood of just spurious test results. So I'm going to jump in with thinking about biotin. I don't know if you have lots of people in your part of the world who are taking biotin as a supplement for hair or nails, but in the US, it's really common. For whatever reason, in the last few years, this has taken off. And what we have learned, since we have lots of patients who are taking these supplements and may not tell us about them, is that they can cause really markedly abnormal results on thyroid function testing. So TSH is measured by sandwich immunoassays. So you need a detection antibody and a capture antibody. They bind to each end of the TSH molecule in order to sort of get it to light up and to signal and to be counted. A lot of assays are bioatenylated assays that just take advantage of the fact that biotin tends to bind really, really tightly to streptavidin. And when you bind that biotin to the streptavidin as part of your assay process, you can kind of anchor molecules in place and allow them to be counted. So in patients who are on taking high dose biotin, it can disrupt the TSH testing. The biotin occupies the streptavidin binding sites, so you can't get this sandwich bound to them and counted, and basically it will undercount TSH. It will make TSH look artificially low. And at the same time, we have the opposite effect on peripheral thyroid hormone tests, that T3 and T4 are not sandwich assays, they're competitive assays. So the effect of having a lot of biotin floating around in the serum on these competitive assays is to cause an artifactual increase in levels. So you can have somebody taking biotin who's completely euthyroid, who looks biochemically exactly like somebody who has Graves' disease. The TSH is low or undetectable, the peripheral hormones are high. So the key is just to be alert to this issue and to suspect it perhaps if you see a patient with labs that look like biochemical hyperthyroidism and a clinical picture that does not. It's said that you can start seeing these artifacts in the assays that are susceptible to this interference in people taking 5 milligrams a day or more of biotin. And it's pretty easy to get around it. If you know people are taking the biotin, you just tell them to stop for 2 or 3 days before you repeat lab tests. Most of the other substances that can cause, just completely spurious thyroid function test results are related to the presence of antibodies in serum. And kind of the classic scenario here is the heterophilic antibodies, or sometimes known as HAMA, human anti-mouse monoclonal antibodies. So we don't know exactly what the prevalence of these antibodies is in the general population. I've seen estimates probably less than 1%, so it's not enormously common. But people who happen to make these antibodies, these HAMA antibodies recognize mouse monoclonal antibodies that are used in these TSH sandwich immunoassays. So they can create a link between the capture antibody and the signal antibody, even when TSH isn't there. So these are going to cause a spurious increase in TSH, make the TSH artifactually high, even when somebody's euthyroid. And because a lot of the assay manufacturers recognize that this is a potential problem, some of the automated assays have a built-in pre-incubation of patient serum with non-immune mouse autoantibodies to try and get rid of this the HAMA effect. But one can still see this occasionally in patients. Now, other antibodies that may cause spurious thyroid function test results are antibodies that we can see in some of our patients with Hashimoto's. So in addition to the TPO antibodies and the thyroglobulin antibodies that we measure in these patients, some of these individuals also happen to have circulating antibodies against T3 or against T4. And we don't think that has clinically significant effects on thyroid function, but it can kind of mess up our ability to measure thyroid hormone. Because in these one-step competitive assays for T3 and T4, if you've got these anti-thyroid hormone antibodies circulating, that can cause falsely elevated thyroid hormone results. And these antibodies can persist for months or years. They can stick around for a long time in the people who have them. So if you see these disproportionately elevated thyroid hormone levels that seem to not match the TSH, which should be normal, these are not hypothyroid patients necessarily, or hyperthyroid patients, one can measure by a different method, often by something like equilibrium dialysis, which will not be susceptible to the same assay interference. And one final sort of form of antibody that can interfere with our ability to measure thyroid function, this is something we think about more with prolactin assays. We think about macroprolactin, but there's also sort of this issue with potential macro TSH. And again, this is uncommon. Maybe about 1% of people have TSH, anti-TSH antibodies circulating in the blood. And again, these don't have clinical effects on thyroid function, but these circulating anti-thyroid antibodies can bind to anti-TSH antibodies can bind to the TSH that's circulating and make these big molecules that cannot be readily cleared by the kidneys. So these big clumps of TSH and TSH antibody are not biologically active. Patients will be euthyroid, but it will tend to cause a spuriously elevated TSH because these complexes are picked up by TSH assays. Now, the range of TSH elevation in these patients that's been described is anywhere between 5, and I honestly don't know how you would ever figure out that a TSH of 5 is just a spurious elevation, but elevations up to 700 something, which would certainly get your attention. So if you suspect that you've got a spuriously elevated TSH, there are a few ways to get at this. For any of these interferences, one way to try and assess whether results are real or not is to do serial dilution of the sample. Because if you have interfering substances in the sample that are causing the problem with the assay, as you dilute that out, you are diluting out those interfering substances. And as you plot concentrations across different levels of dilution, you will get nonlinear results. Whereas if this is a true result, that concentration will remain linear. Other ways to deal with macro TSH, you can precipitate it out with gel filtration chromatography or with polyethylene glycol. And we as endocrinologists are not necessarily well versed in all the ins and outs of lab medicine. So I think the key is if you think you may have spurious results based on thyroid function tests that don't match up with each other or don't match the clinical picture, to think about just measuring in a different assay to see, if the interference persists. And if that doesn't work, to try some of these other steps, the polyethylene glycol precipitation and, measuring for HAMA antibodies are a couple of ways to get at this. So now thinking a little bit about binding globulin changes, things that are going to affect, in theory, mostly just total T3 and total T4 levels, but that can sometimes also affect our measurements of the free hormones. The first one to think about is something that's also rare. This is familial dysalbuminemic hyperthyroxanemia, or FDH. This is caused by a single gene mutation on the ALB gene. And it's uncommon, probably less than 1% in most populations, although it's up to 1.8% in individuals of Hispanic descent. And these are patients who just have increased binding of T4 to binding globulin. So you get an elevated total T4, not so much an elevated total T3 level. If we have really accurate methods for measuring the free hormone, it will be normal. So if you measure free hormone in these patients by equilibrium dialysis, it's normal. But our assays don't tend to cope very well with very high or very low levels of binding globulin. So in these patients, even though in theory the free T4 should be normal, the lab may not be normal. TSH should not be affected though. So this is just a demonstration measuring serum from patients with FDH across a number of assays. In some of them, you can see a normal free T4, which is what you should see, but in some of them, the free T4 is spuriously elevated, and that's just, again, kind of artifact because the assay can't handle that high level of binding. Other hereditary alterations in binding globulins that, again, are uncommon but useful to know about. One is hereditary thyroxine binding globulin excess. This is inherited in an X-linked dominant fashion, and it is rare. It's 1 in 25,000 people. These patients have increased synthesis of TBG, so they'll have high total T3 and T4 levels, and again, presumably would have normal free T4 levels if our assays were really accurate. In males, this is X-linked. So in males, the TBG levels are 2 to 4-fold increase, and they're about half that in the carrier females. Kind of the flip side of that is patients with hereditary TBG deficiency. Partial deficiency is not that uncommon. It's about 1 in 4,000 individuals, but total deficiency of thyroxine binding globulin occurs in about 1 in 15,000 males, and this is X-linked recessive. So in these complete deficiency patients in males, you'll have undetectable TBG, so very low total and T3 and T4. And carrier females will have half the normal TBG concentration. So again, you might see low total hormone values. We also do things to our patients that can alter binding globulins. You know, most frequently we think of estrogen as increasing TBG levels in our patients, but the SERMs like raloxifene and tamoxifen do it too, to a slightly lesser extent. Other meds that can do that are mitotane, methadone, heroin, and fluorouracil. And drugs that can decrease TBG alterations, any of the androgens, nicotinic acid at high levels, and chronic glucocorticoid therapy. Then there's a final category of meds that don't increase or decrease the binding globulins, but displace thyroid hormone from their binding sites on these globulins. So one of those is furosemide. Although this effect is typically only seen at very high doses, typically IV doses, typically this is then going to be in our hospitalized patients where we already have trouble interpreting thyroid function tests of a non-thyroidal illness, and I'll talk about that in a few minutes. But aspirin and all of the NSAIDs to differing extents do displace T3 and T4 from binding sites, so can make the free hormone levels look a little bit high. Phenytoin can do this, and heparins can do this, including the low molecular weight heparins. And with the heparins, it's somewhat time dependent. So this is happening kind of in the test tube as the stored sample is waiting to be measured. The heparin will activate lipoprotein lipase, which will tend to cause an increase in the non-esterified free fatty acids sitting in the test tube with your thyroid hormone samples. And the non-esterified free fatty acids will displace thyroid hormone from binding sites and cause kind of a spurious increase in free T3 and free T4 levels. So the key in measuring thyroid hormone, peripheral thyroid hormone in patients who are on heparin, if you can, try and ensure that this does not sit around at the lab before it gets measured. You want it to be measured promptly so there's less time for this artifact to kind of take place. I want to switch gears now and think about a couple places where we maybe can believe the labs, but the reference ranges don't apply. So the first of those is patients taking amiodarone. And remember that one of the most pronounced amiodarone-mediated effects on the thyroid is that it's just a very potent inhibitor of deiodinase. So it inhibits T4 to T3 conversion. And so what one can see in patients, even the patients who remain euthyroid on amiodarone, is that after initiation of the amiodarone, with that decrease in T4 to T3 conversion, there's less T3 feeding back at pituitary hypothalamus. You get a transient rise in TSH, usually modest, less than to less than 10, as things kind of come to a new equilibrium, and then the TSH comes back down and stays stable. So the first thing to note is just in the first 3 months after starting amiodarone, you can see this transient mild rise in TSH. And after that, the TSH should not really be affected, but that you'll see ongoing effects on T3 and T4 because of the inhibition of conversion. So in patients who are euthyroid on amiodarone, often both the free and total T4 may be a little bit above the upper limit of normal, and the total and free T3 may be just a little bit below the usual reference range, even in patients who are fully euthyroid. Now, the other place where we have to think carefully about how to interpret thyroid function tests is in pregnancy. And we talked earlier today about the effect of HCG in early gestation. So HCG stimulates the thyroidal TSH receptor, causes an increase in thyroid hormone production, which feeds back and causes a decrease in TSH. So often in early pregnancy, the TSH is just a little bit lower than outside the pregnancy setting. And this is probably to some extent assay specific and population specific, but a reasonable rule of thumb based on the current guidelines is that you can use an upper limit of TSH of about 4 in early gestation. And after that, by mid-second trimester, you can probably go back to using the non-pregnancy reference ranges for TSH. Measurement of peripheral thyroid hormone is complicated in pregnancy, again, because of major alterations in binding globulins. So the high estrogen levels in pregnant women will drive an increase in thyroxine binding globulin that will drive an increase in total T3 and T4 levels. And again, as is often the case, when the binding globulins are really high or really low, it just confounds the automated free T4 autoassays. Probably even more so for free T3, and I would not use free T3 measurements in the pregnancy setting. Now, we don't have a great workaround for how to assess free T4 in pregnant women. One way to do this, if your lab still has the older way to do this measurement, is to not do a direct immunoassay for free T4, but to do a free T4 index, where you measure the total T4 and some index of binding, and then you can calculate the free T4 levels. And it's been shown that the free T4 index correlates better with gold standard methods like equilibrium dialysis than do the automated methods for free T4. But not every lab has the free T4 index still available. It's been phased out in a lot of places. Another workaround is by using the total T3 or total T4 as a surrogate for your free hormone. And we can do that because the TBG is changing in a pretty linear and pretty predictable fashion in early gestation. So you can think about it as starting to rise at week 7 and plateauing at week 16. And you can therefore take your non-pregnancy upper limit of normal for either total T4 or total T3, increase by 5% starting at week 7 of gestation, increase by 5% per week until you get to week 16 when things plateau. And at that plateau, you can use 150% of your upper limit of normal for the non-pregnancy range. So again, you can sort of construct your own gestation age specific ranges and use total T3 and total T4 to estimate your peripheral hormones. Now, that's kind of all the places where I think about potentially spurious results or results that need to be interpreted with caution. But there are other times when the assays are simply discordant with each other. The TSH does not match the peripheral hormones, or they don't match, the peripheral hormones kind of don't match each other. And as I said, I think this is sometimes when clinical thyroidology gets most interesting, because this is when you have to think about some of the more unusual potential causes. Now, the first one of these is not unusual. This is non-thyroidal illness, and anybody who takes care of endocrine patients in an inpatient setting will see this pretty frequently. So any form of severe non-thyroidal illness will cause really marked shifts in thyroid function. And these changes happen fast, even within the first 24 hours of severe illness. They can happen with really any major stressor for the body. So starvation, sepsis, burns, cancers, MI, surgeries, chronic liver or renal disease, and even major psychiatric illness. And it's really interesting that these illnesses seem to trigger changes in really every step of thyroid hormone synthesis and metabolism and action. So severe illness will trigger a fall in thyroxine binding globulin levels and or impaired binding of hormone to the binding globulins. It will reduce hypothalamic TRH secretion, which will impair pituitary TSH secretion, so decreased thyroid hormone synthesis will result. It will decrease cellular uptake of thyroid hormone, alter deiodinase activity, and so one of the hallmarks of this is sort of a shift from conversion of T4 to T3 to shifting down the other pathway conversion of T4 to the reverse T3, the inactive hormone. And also we see altered expression of thyroid hormone receptor and altered thyroid hormone receptor signaling. So profound changes, whether these are pathophysiologic or physiologic is debated. The classic sort of pattern that you will see can be a little bit variable in terms of severity and acuity and sort of time to resolution of illness. But typically the first change we see in non-thyroidal illness is a decline in serum TSH levels, which will be followed fairly promptly by a decline in total T3 levels. And if we measure it, although it's usually not of any clinical significance to do so, when that T3 declines, you see a sort of a concomitant increase in reverse T3. That's probably a deiodinase effect. Now, if patients get really sick, in addition to the T3 dropping, you'll also see declines in total T4 levels. And that is in the sickest patients. And in fact, having low total T4 levels in severe illness is actually a pretty good predictor for risk of mortality. The free T4 is less predictive here, and it's much more variable because, again, you got alterations in binding globulins, and our free T4 assays don't cope with those alterations very well. Now, as patients recover, the first change you'll see is that the TSH starts to increase, and in fact, it often increases to above the normal reference range. Usually not more than 10, really never more than above 20, but you may see a somewhat high TSH transiently that will sort of pull up the peripheral hormones, the T4 will normalize and then the T3 will. But depending on when in the course of illness or the course of recovery you do your measurements of thyroid hormone, you can of course see thyroid hormones that really seem very discordant with each other. And most frequently when we're seeing patients with these really deranged levels, in the inpatient setting, we say, please wait and repeat the labs, in 4 or 6 weeks when the patient's healthy, because we really just can't interpret them in the acute illness setting. Now, another disorder that can cause sort of discordant thyroid function tests is thyroid hormone beta resistance. And biochemically, what you will see in these patients are mildly elevated T4 and T3, with a TSH that is also mildly elevated or is inappropriately normal. This is uncommon. It's 1 in 19,000 to 1 in 40,000 live births. It's transmitted in an autosomal dominant fashion, and about 20% of cases are de novo. So in those 20% of patients, you won't get a family history for this. There are quite a lot of mutations that have been identified, and genetic testing is available for this disorder. What you will see clinically is effectively governed by the fact that we have 2 types of thyroid hormone receptors, alpha and beta, and they're predominantly expressed in different tissues. Because it's the beta receptors that are resistant to the effect of thyroid hormone, what you will see is effectively tissue-level hypothyroidism in those beta tissues, which are mostly liver, and also the pituitary, which will impair normal feedback. So those tissues are relatively hypothyroid, and the alpha-expressing tissues, heart, skeletal muscle, brain, where there's no resistance, are going to be comparatively a little bit hyperthyroid. And so what that means in terms of patients is most will have some goiter. Most will have tachycardia because the heart is seeing excess thyroid hormone. Most will have some kind of central nervous system manifestations, either anxiety or attention deficit hyperactivity disorder. And in a minority of patients, you also see effects on hearing and on growth. Now that can look biochemically identical to the next rare disorder, even rarer disorder, which is TSH secreting adenoma. So this is a 1 in a million diagnosis. This is rare. And when this was first described back in the 1960s, we didn't have great thyroid hormone assays or imaging. And so the patients who presented were floridly hyperthyroid. And when people have florid hyperthyroidism, it's pretty easy to make this diagnosis. But when hyperthyroidism is mild, you may see a clinical picture biochemically that looks just the same as the TSH beta receptor mutation that I just showed you, where you get slightly high thyroid hormone levels and slightly high TSH. Goiter is common in both conditions. And so ways you can tease this out from each other, is this mild TSH secreting adenoma versus the resistance syndrome. MRI of the pituitary is helpful because most of the adenomas that are secreting enough TSH to be clinically apparent are macroadenomas, so you will see something on imaging. Family history is helpful, but remember that 20% of mutations are de novo, so there's not always a family history. Measurement for the genetic abnormalities is helpful too, but 14% of cases currently we don't have a known mutation for, so it's not always going to give you the diagnosis. Sometimes we rely on markers of thyroid hormone hyperfunction, like increased sex hormone binding globulin, P1NP, and decreased cholesterol in patients who are hyperthyroid from TSH secreting adenoma. Those will be normal in the resistance, or a T3 suppression test. If you give people a huge dose of T3, and don't do this in people who are very sick or very fragile, you can suppress the TSH secretion in patients with resistance, but it will not suppress in a TSH secreting adenoma. And then finally, the last sort of rarer scenario is central hypothyroidism. It says 1 in 20,000 to 1 in 80,000 individuals. The hallmark, of course, would be low free T4, but the TSH can be misleading here because sometimes people secrete a bioinactive TSH. And so what's seen on labs is a TSH that's inappropriately normal for the low free T4 or possibly even mildly elevated. So I would conclude by noting that when you see labs that don't make sense, the thyroid function doesn't match the clinical picture or the thyroid function tests don't match up with each other, think about these different causes of spurious results and think about some of these rarer syndromes where these discordant results are really real. And with that, I will thank you for your attention.
Now we introduce Professor Christine Pollard, is a professor of endocrinology at the University of Birmingham. Her clinical research interests include the management of thyroid dysfunction, nodule, and cancer. She was the co-recipient of Outstanding Clinical Practitioner Award from the Society for Endocrinology, and she was the clinical lead for NICE guideline on thyroid disease and leads the National Consensus Statement on Management of Thyroid Cancer. She has rapidly growing list of publication, and she is also a senior editor for Endocrine Connection and the Journal of Endocrine Society. And she is also a member of Society for Endocrinology Council and the Clinical Committee, the American Thyroid Association Award Committee. She will present a topic about central hypothyroidism.
Thank the organizers for asking me to speak on central hypothyroidism. I'm Christine Pollard, a professor of endocrinology from Birmingham in the United Kingdom. These are my conflicts of interest. What I will cover today is a little bit on the physiology of TSH secretion and then move on to the prevalence and etiology of central hypothyroidism. I will look at diagnosis and management of central hypothyroidism, and then I have a few slides on congenital central hypothyroidism. So compared with primary hypothyroidism, which has a prevalence of about 1 in, or primary congenital hypothyroidism, which is a prevalence of 1 in 1,500, central congenital hypothyroidism has a prevalence of about 1 in 16,000, so an order of magnitude difference. And when we talk about central hypothyroidism, this really means that we have either hypothalamic or pituitary disease. And the left-hand side here illustrates once again how thyroid hormones are secreted. So we have TRH from the hypothalamus, which originates from pro-TRH, which is then cleaved to TRH, and that will bind to TRH hormone receptors on the pituitary gland, which will, within the anterior pituitary, result in a coupling of the TSH alpha and beta chain. So we have mature TSH, and that will bind to TSH receptors on the thyroid gland, producing T4 and T3. And as we are all aware, there is a negative feedback mechanism in place. And similar to many other hormones, such as cortisol and ACTH, there is a diurnal variation in TSH secretion. And this generally usually peaks in the early hours of the morning, so just after midnight in the early hours of the morning, as is seen here in a TSH profile of a healthy volunteer. So central hypothyroidism really encompasses a spectrum, but generally is characterized by a low TSH, and compared with what we find in the more common primary hypothyroidism, this will be associated with a low free T4 and a low total of free T3. But of course, this can be a spectrum, and the degree in which free T4 is reduced can be quite varied, and especially when this is only just reduced, or especially if TSH is near the normal range, or even in some cases is raised, this can lead to some diagnostic difficulties. So we have a number of supporting features in the clinical, radiological, and biochemical field. So often clinically, there will be hypothyroidism. And of course, if there are a number of predisposing factors, then that would sway the evidence towards this being central hypothyroidism. Again, radiologically, if you have abnormal hypothalamic or pituitary imaging, that gives us a clue. And physiological, there may be changes in cholesterol, CK, and ferritin, and this can be characterized by bradycardia. Indeed, a number of papers have suggested that there may be some cardiac echo parameters that can help us distinguish primary from secondary or tertiary hypothyroidism. And of course, if there are additional pituitary deficits, then that gives us a clue. And in someone who has had a pituitary event, declining T4 levels, again, gives us a further indication. As is always the case when you have what we would call a slightly funny thyroid function test, i.e. TSH, T4 and T3 all being low, make sure that there is no assay interference, because again, there is a biochemical spectrum here of this disease. And a differential diagnosis really has to be considered, and a number of things to consider here. Time won't allow me to go into too much detail here, but there are a number of other conditions that can give a very similar biochemical pattern, such as non-thyroidal illness, people who are recovering from thyrotoxicosis, or people who have TBG deficiency. This table here lists the causes of central hypothyroidism. In adults, this can also occur in children. This can be due to invasive or compressive lesions of the pituitary sella. There may be some iatrogenic causes, and a number of drugs really have been implicated, or irradiation to the pituitary gland or the hypothalamus. Injuries, including head trauma, vascular accidents, a pituitary infarction or Sheehan syndrome, a number of autoimmune diseases, particularly hypophysitis, infiltrative lesions, and then there's quite a big cohort of these patients that actually have a genetic defect, and I will come back to this. This is often a sporadic form of hypothyroidism and can affect patients of all ages. Whilst a number of the genetic causes are X-linked, there is no clear evidence of a sex predominance, and the prevalence rates in adult and neonatal populations are given here. Like I said, it can probably be subdivided into inherited or acquired causes, but even in those with inherited central hypothyroidism, it may take a number of years for this to present itself. So how do we diagnose it? Well, if there are a number of pointers within the history, such as a history of central hypothyroidism in first-degree relatives, evidence of delayed growth, macroorchidism, or other defects, again, can point us in the right direction. If we know that a patient has a mutation in one of the candidate genes, or if there is insufficiency of other pituitary hormones. There are also a number of more specific tests that we can do, and I will explain these in the next few slides. So what's been suggested is that this may be diagnosed by looking at TSH bioactivity. And this here is a study that's looked at patients with secondary, so this is pituitary hypothyroidism, hypothalamic hypothyroidism, and primary hypothyroidism. And this here is the ratio between bioavailable and immunological TSH. And you can see that this ratio really is quite low in central hypothyroidism, whereas it is definitely higher in primary hypothyroidism, where it is more towards the normal end. This circadian rhythm that we get in TSH that I showed on the first slide often again is blunted in central hypothyroidism, whereas this would be what is found in normal controls. A number of other authors have suggested calculating a TSH index based on a logarithmic transformation of TSH and taking T4 into account. And you can see that central TSH deficiency sits in this part of the curve here, and the formula in which this can be calculated is given here. So very much dependent on the free T4 concentration. And this graph here quite nicely indicates how it may be very difficult to diagnose this condition because indeed there is an overlap between normal TSH concentrations in children and then TSH concentrations in children affected by central hypothyroidism. And you can see that there is a large area of overlap here where the biochemical test may not be that clear, where there may be mild central hypothyroidism. And like I said, we need to be on the lookout for this because this could be missed. And of course, we could do a TRH test. And again, this is what many guidelines recommend that we do. So this is injecting 200 micrograms intravenously of TRH, and you look at the TSH responses. And the graph on the left here shows what a normal response would be, where you get a peak in TSH and that then generally comes down. And this is very much blunted in patients in red here affected by central hypothyroidism. In some instances, this may be a delayed peak in TSH. Again, what you see here is a relatively, these are all patients that are affected, although this patient here has a relatively normal response. But you can see that for many of these patients, the peak comes late, so after 60 minutes, and it also takes a much longer time to come down. This has a poor sensitivity as a diagnostic test. But if results are abnormal, in addition to a number of other factors or tests, this may help us. It may also help to distinguish between pituitary and hypothalamic disease, and may also predict whether there are whether it's likely that there are multiple pituitary hormones that we are deficient in. So looking then at acquired central hypothyroidism, this here is a study that looked at patients who've undergone pituitary radiotherapy. This is 107 patients followed up over a median duration of 8 years. And you can see that actually the TSH axis tends to be one of the least sensitive axes in this situation. So often it is growth hormone deficiency that is most pronounced and that comes first. And of the pituitary, anterior pituitary hormones, TSH deficiency is less common and also is one of the ones that presents slightly later. However, we do need to monitor patients for central hypothyroidism if they have had pituitary radiotherapy. And then this is quite a nice audit of 514 patients who either had pituitary hypothyroidism compared with patients who had primary hypothyroidism or primary hyperthyroidism from database. And you can see, so what I'm taking you to here are the free T4 concentrations that were either very low, below 11, or below 13. So patients with pituitary disease, quite a significant proportion of them really had low free T4 concentrations when compared with patients who were either receiving levothyroxine either from a database or because they were on the thyrotoxicosis follow-up service. And the other thing that is notable here is that even those patients who are taking T4, both who had a low risk of developing pituitary deficiency and those on high risk, actually weren't adequately treated, with significant proportions here being undertreated and under-replaced with levothyroxine. And then finally, we know that the number of drugs, and these drugs are increasingly being used in a number of conditions, either immunological conditions and in cancers. Ipilimumab is one of the first ones that was identified, but a number of these monoclonal antibodies have been associated with central hypothyroidism. This tends to be more common in males than in females, and the risk increases with age and with increased dose of the medication. Often, TSH deficiency can be reversible, and it most commonly will present 2 to 3 months post-initiation. A number of other drugs specifically have been linked to central hypothyroidism, rexinoids, mitotane, and then a number of the other drugs that are listed here. So again, taking a good drug history is really important. And so this algorithm is from the European Thyroid Association guidelines on how to manage central hypothyroidism. So patients with a low T4 and an inappropriately low TSH, so that is your biochemical diagnosis. Ideally, you confirm that on 2 occasions. You then obviously would do an evaluation of clinical manifestations and make sure there is no assay interference. If this is a newborn, you really don't want to waste time, and you collect personal and family history, but also start treatment as soon as possible. A skull MRI may be very useful here. If the baby or the person has macroorchidism, then this will point towards a heritable cause of central hypothyroidism, and genetic analyses may be required. If you find a pituitary or hypothalamic lesion, then again, that may point towards acquired isolated central hypothyroidism, and that may require treatment. Again, like I said, taking a drug history, taking a history of whether the patient may have had an accident, or whether there possibly is a history of pituitary infarction, which again may then point towards either acquired isolated or multiple pituitary hormone deficiency, and this will require treatment. How do we treat? Well, you need to, like always, when you start levothyroxine replacement, make sure that the cortisol secretion is intact. Like I said, often these patients have multiple pituitary hormone defects, so make sure there is sufficient cortisol present in the person. And then you start at a full dose, i.e. 1.6 micrograms per kilograms. My next slide looks at a trial that has been done of looking at T3 and T4, which is not generally recommended, but in patients who really don't feel well with T4, an experimental approach may be considered. In congenital central hypothyroidism, a starting dose of 10 to 12 micrograms per kilogram body weight, ideally within 2 weeks of birth or 2 weeks of diagnosis, should be started, and younger children often require higher doses. So this was quite a nice trial here, where they looked at patients with central hypothyroidism who were either treated with an empirical dose of T4, a body weight adjusted dose, or a combination treatment. And you can see that those patients who went on combination treatment had supraphysiological doses of T3, so the supraphysiological concentrations in their blood. When they looked at parameters such as cholesterol, it is the weight adjusted dosage that resulted in better outcomes in relation to cholesterol, in relation to BMI, and there was no difference whether this was T4 alone or T3 and T4. And when they looked at quality of life scores, there was no benefit from giving combination therapy. So the upshot from this study was that the best way to treat it is levothyroxine monotherapy, starting at micrograms per kilograms. So how do we monitor? Well, we only have free T4 really in which we can monitor this. TSH is unreliable. For children, ideally use age-adjusted reference ranges. And be aware that in situations such as someone becoming pregnant, someone going through puberty, someone going on estrogen replacement, or starting growth hormone replacement, an up titration of T4 may be required. And as I've already said, often there are multiple pituitary hormone deficiencies, so these replacement therapies may well need to be started in these patients. So close monitoring of their biochemistry, thyroid biochemistry, and up titration of the dosage if needed. So do we pick this up on screening for congenital hypothyroidism? And across the globe, most newborns are screened between days 3 and 7 of age for congenital hypothyroidism. And in most of the world, this is based on a TSH assay. Now, of course, in many of these patients, TSH will be normal, and it will therefore not detect central congenital hypothyroidism. In a number of countries, they use T4 with TSH, and that will detect both primary and central congenital hypothyroidism. It is a relatively rare condition, but in a significant proportion of babies will be moderate or severe. And in many of these patients, in many of these newborns with genetic defects, there will be other pituitary hormone deficits. So doing an assay where you measure both TSH and T4 may well have significant benefits. So this slide here illustrates the most prominent genes that have been implicated in congenital central hypothyroidism, and the two here that I've highlighted will be the ones that I just will have a brief discussion about. So this is either a mutation, an autosomal recessive mutation in the TSH receptor beta, or it can be a mutation in the immunoglobulin superfamily 1 gene. So looking at TSH beta mutation, this here is a study that looked at 3 different children that were born with congenital central hypothyroidism. This first baby, this was diagnosed at 14 weeks. And again, we have the typical biochemistry where you can see a TSH that was normal with a very low T4. And you can see there was a mutation in the TSH beta gene. There was then a family of 2 siblings, one who presented at 6 weeks, so the same mutation they had in the TSH beta gene, and you can see that their clinical spectrum was quite varied, so this baby did really not have any deficiencies. This first baby here had profound hypothyroidism, and this was diagnosed with a blunted TRH response and a raised alpha subunit. So the other mutation that I want to look at is a mutation that is X-linked. So central hypothyroidism will ensue in 100% of males, but a number of pituitary cells are affected: thyrotrophs, lactotrophs, somatotrophs, and gonadotrophs, and often, therefore, these other deficiencies will be present. This is almost always associated with macroorchidism. So IGSF1 mutations can be diagnosed if you have a child with macroorchidism and a suggestion of TSH deficiency, then certainly do a genetic analysis for this mutation. And this slide here, so I thank Nadia Schoenmakers for providing me with some of her very beautiful slides. She's of course an international expert on this, but you can see that the genetic defects can be subdivided into isolated TSH deficiency or those that are associated with a number of other abnormalities. The ones that I've highlighted are the ones that result in isolated deficiency. IGSF1 deficiency, as I illustrated, is an X-linked condition associated with macroorchidism, or mutations in TSH beta, where often there are no other syndromic features, but features are of profound congenital hypothyroidism, often with significant mental retardation. So in summary, central hypothyroidism may be congenital or genetic or acquired. The diagnosis has a number of pitfalls and may therefore be missed. The clinical presentation and severity can be quite varied, and if this is congenital, it is often associated with other pituitary hormone deficits. The recommendation is that you treat with rate-based levothyroxine monotherapy, and that you are aware of additional pituitary hormone deficiencies, either because they are present because there is a congenital abnormality, or because the patient is developing acquired pituitary hormone deficiency, including TSH. Thank you for your attention.
So good evening again. Hello, everybody. So it's also our great pleasure for us to introduce our third speaker for this session, who is going to talk about Graves' disease in adults, Dr. Saleh, Professor Saleh Al-Dessouqi. He is a professor of medicine and the chief of endocrinology in the College of Human Medicine, and the director of the endocrinology fellowship program at Michigan State University. So Professor Dessouqi has his clinical and research interests include neck ultrasound, Graves' disease diagnostics, Graves' disease association, thyroid cancer, hypoglycemia, diabetes diagnosis and screening, lipid testing, clinical empathy and laboratory diagnosis, and IT in medicine. He has over 60 peer-reviewed publications and over 100 abstracts and over 100 blogs and posts. The talk is yours, Professor Saleh. Thank you.
بسم الله الرحمن الرحيم. أنا دكتور صالح الدسوقي, Chief of Endocrinology at Michigan State University. I would like to thank the organizers of this wonderful first Congress or Symposium of the Arab Thyroid Association. موضوع المحاضرة Graves' disease in adults. طبعا Graves' disease is an interesting disease. We shouldn't say interesting for patients' diseases, but it's kind of like a fascinating in a scientific way. Graves' disease, before I start, I would like to disclose my commercial. disclosures, kind of. So I consult for about laboratories. So I would like to dedicate this presentation to my teachers in thyroid, late Dr. Dan Dewick and late Dr. John Crockett. And these were pillars in the world of diabetes. Dr. Dewick at a national and international level, and Dr. Crockett at our regional level at MSU. And I think the colleagues, they know that Dr. Dewick is a pillar in, or was a pillar in thyroid cancer and thyroid diseases. And he started with other colleagues the program in certification in ultrasound, NIC ultrasound, ACNU. And I had the honor and pleasure to have worked with Dr. Dewick in the 90s. So I'm from East Lansing, Michigan, and I'm with MSU. And you know, Michigan is the home of GM, Chrysler, and Ford. These cars are made here around us in Michigan. And this is our medical school. We have two campuses, one in Grand Rapids and one in East Lansing. And this is Dearborn, and Dearborn, Detroit, Michigan is considered the Arab capital of America. Over 40% of the population of Dearborn are Arabs. And this is a typical street. You think you are in an Arab country. And these are some views from Michigan, Dearborn, Michigan. And this sister is mowing her lawn, يعني بتقص الحشيش in her house. So the thyroid gland is kind of like a butterfly structure in the bottom part of the neck. And this is a picture I borrowed from my friend, Dr. Omar Abu Hajle from Jordan Hospital in Jordan. So the thyroid gland is about 25 grams in weight, and the dimensions are just below 5 centimeters in length and about 2 centimeters in width, as well as in anteroposterior dimension. And the thyroid gland is can be looked at as the letter H, as well as a butterfly. And this is the worksheet for thyroid biopsies that we have at our clinic. And cutting through the thyroid and going from anatomy to histology and biochemistry and physiology, that's another talk for another day. But again, it's an interesting gland, the thyroid is. And this is another slide from our curriculum at MSU, which again shows the different kind of like views where the control of the thyroid from the hypothalamus and the pituitary, as well as the gland, and cutting through into the histology of the thyroid. And this is a follicle, thyroid follicle with the thyroid cells and the colloid in the middle. And this is another a reminder of the biochemistry and physiology of the thyroid, showing T3 and T4 and the differences between the two, which mostly lie in the iodine position here, which is missing in T3. And I put this slide together some years ago to describe the thyroid physiology and pathophysiology in kind of like a spectrum of this thyroidism, with hypothyroidism on the left and hyperthyroidism on the right. And in the middle is a euthyroid patient. And this picture I got from this reference, which is a publication in the 19th century in the journal Medico-Chirurgical Transactions, depicting a patient going from euthyroidism into subclinical hypothyroidism into more overt myxedematous-like hypothyroidism. And the thyroid hormones can be looked at gas, the gas, like, or the gasoline or benzene, the sayara. So when the gas, when the driver pushes on the benzene accelerator, the car moves very fast, and when the gas is low or the benzene is low, the car moves slowly. And that's what happens in hyper and hypothyroidism, respectively, because the thyroid hormones affect almost all body systems. And if you look at the thyroid pathology and pathophysiology and the labs, we have to distinguish between primary thyroid dysfunction and secondary thyroid dysfunction, where in primary, the TSH and the T4 and the 3, they have an inverse relationship as compared to central dysthyroidism, hyper and hypo, where the TSH and the hormones, they go kind of like together, hand in hand. And so that's an introduction which will introduce us to the two main diseases of thyroid, like Hashimoto thyroiditis and hypothyroidism on the left, and Graves' disease as the main etiology for hyperthyroidism or thyrotoxicosis here on the right. And so that introduces us to Graves' disease, which is generally uncommon under the age of 15, although cases of pediatric Graves' disease are known. And I've seen when I did pediatric endocrinology many years ago at Indiana University, I saw some young kids with Graves' disease, like ages 4 or 5 or 6. And it's kind of like is the commonest cause of hyperthyroidism pretty much around the world, and definitely in the US, causing more than 80% of cases. It's commonest in the 3rd and 4th decades of life, more common in women, as we know, and can be associated with eye disease as well as skin manifestations, as we all know. So it's Graves is just the name of the doctor who described it, and it's not a grave, and that's a little bit confusing here for us in America and in the West, where the word grave it does not sound good. In the Arab world, I'm not sure this is a problem as we communicate with patients in Arabic. And I worked in Qatar and Saudi Arabia in the past, so this was not an issue. Historically, Graves' disease is probably the only disease that has so many names, like Graves, Basedow, Perry, and then Begbie, Flajani-Basedow, and Marsh. But actually, I was surprised to know, as I was preparing this lecture, that actually Graves' disease was described in the 12th century by the Persian Muslim doctor and philosopher Al-Jurjani, and he described that in his famous book Tashrih al-Khawarizm, al-Malik Khawarizm, أعتقد. It is described in the literature as the most famous anatomy book or encyclopedia of medicine in the 12th century around the world at that time. But regardless of what we call it, well, it's called Graves' disease, at least in most parts of the world. In Europe, they call it Best-Dow disease, I guess, or some parts of Europe at least. So it's an autoimmune disease that is characterized by hyperthyroidism with various degrees of diffuse goiter, associated but not always with ophthalmopathy and rarely with dermopathy. And these manifestations are believed to be triggered by autoantibodies grouped under the class of thyrotropin receptor antibodies, TRAP, with the TSI being the stimulatory component of these immunoglobulin groups. And this is a nice depiction of how the immune mechanism starts in Graves' disease. And so the TSI or the TRAP stimulatory component will cause stimulation of the gland, whereas there is a component which is the blocking component of a TRAP that can block the thyroid, at least theoretically. And it is not uncommon, Graves' disease is not uncommon, about 0.5% of the population may have it. And as we said, up to 80% of hyperthyroidism is caused by Graves' disease. Female to male ratio can range from 4 to 9 in some series to 1 as compared to males. And obviously the vast majority of patients with Graves' disease in my practice, and I'm sure in the practice of so many endocrinologists, are actually women as compared to men. The age peak, third to fourth decade, but again, it can be seen in pediatrics and geriatrics. So what are the symptoms? You know, if you look at any textbook, you'll find a table of symptoms and signs, which, you know, all of us know. And as far as labs, TSH is the most important lab. However, we have to be careful about central hypothyroidism. Free T4 is mandatory to confirm and verify the diagnosis. Free T3, we do order it in a good percentage of patients with Graves' disease, so that we can understand the severity. And mind you, there is a more production of T3 as compared to T4 in cases of Graves' disease as compared to other causes, such as thyroiditis or gestational thyrotoxicosis, other causes of hyperthyroidism. TSI and TRAP, we talked about that. And remember, biotin in people who take biotin as a beauty product or supplement, it can interfere with lab tests, and it can create a confusion, it can create kind of like a misdiagnosis of Graves' disease, where the patient does not have Graves' disease, but it's just or hyperthyroidism. It's just a lab interference. Now, what imaging do we use in the workup of Graves' disease? Of course, nuclear scan or radioactive iodine scan is the standard of care in the diagnostic workup. But now there is an emerging role for ultrasound, or it's no longer emerging. We've been doing ultrasound in Graves' disease for 15, 20 years or more. And we feel that it's probably a better diagnostic tool than radioactive iodine nuclear scan. And I'll talk about that in a minute. So this is the nuclear scan, and this is how you know, the uptake, the diffuse uptake appears in Graves' disease as compared to normal. This is like a case report that we published many years ago, where the uptake was read as 106% at 24 hours, which I don't know how that can be calculated, but this patient has a very, very severe case of Graves' disease and hyperthyroidism. So ultrasound is a different kind of sound, and ultrasound is above the human's ear ability to hear. So we can hear up to 20 kilohertz of sounds. So this is the audible sound for the human ear, and certainly there is infrasound, such as that is used in the technology of earthquakes and things like that. And so this is the ultrasound probe, which emits the ultrasound wave. They get reflected back, and we get the image accordingly. And historically, the Titanic sank just 2 years before the discovery of ultrasound or sonar. And if there was a sonar on board or in the Titanic, it would have seen the iceberg, which would have been, extending down here, but the pilots or the captain didn't see it, and so they crashed into the iceberg, and the Titanic sank. So a classical image of ultrasound here shows these structures, which we all know. And this is our ultrasound suite and biopsy suite. This is Dr. Hibdon. This is not a patient. Dr. Hibdon is, or he just retired, but he has been with us for many years. We've been doing the biopsy on patients here at MSU for over 12 years or so. And before that, I used to do that in Cape Girardeau, Missouri. So this is actually not a patient, or actually a patient, but that's me. This is my ultrasound. This is a transverse view, and this is a longitudinal view. Now, so ultrasound versus radioactive iodine. Of course, ultrasound is more portable, it's safer. We can do it in pregnancy. Nuclear scan is laborious and time consuming. There is a potential risk of radiation and so on. So that's why we feel that ultrasound is more helpful, or actually more practical in confirming the diagnosis of Graves' disease. In a radioactive iodine-based classification, in Graves' disease, of course, these are the lab, but will have high uptake. In subacute or destructive thyroiditis, the uptake will be low, and in gestational thyrotoxicosis, it will be high, but we don't do nuclear scan in thyrotoxicosis, in gestational thyrotoxicosis. And so this is the classical so-called inferno, or this is the vascularity of a classical case of Graves' disease. You see the increased vascularity, which is referred to as inferno, يعني نار الجحيم, أو if you wish. You could see that the gland is so vascular as compared to my gland, which has normal vascularity. So these pictures of inferno, these have been known in the literature for so many years, but endocrinologists have not paid attention to this. I got involved with this many years ago by incidents when I started doing thyroid ultrasound on my patients, and I was really fascinated by the inferno. And so I started writing and doing some research about that, and this is a review article that Dr. Zahrani and Graziano and myself, we published in the Endocrine Practice many years ago, and we were honored that they put our pictures on the cover page of the Endocrine Practice in 2012. And so we advocated that rather than a radioactive iodine-based diagnostic workup for hyperthyroidism, we advocated an ultrasound-based diagnostic algorithm. And one last point, and that is thyroid cancer and Graves' disease. This may not be very common in the literature, but we've come across a strong association between Graves' disease and thyroid cancer, which we have also published about, and we also included that in the review article that I have just described. And there is actually an increased mortality in patients with thyroid cancer if they have Graves' disease. And the reason for that, and this has been known in the literature from the 70s, but like I said, people probably may not have paid enough attention to that. And it's common. Thyroid cancer is more common in patients with Graves' disease, and many studies have confirmed that. And like I said, there is at least one study that that described increased mortality from papillary cancer in the case of associated Graves' disease. And the idea is that perhaps interleukins and TSI may work as stimulators of the thyroid tissue and at the same time thyroid cancer cells. And so it's probably TSI is not mutagenic or carcinogenic. It is just a growth factor, just like testosterone for prostate cancer and growth hormone, or IGF-1 for other cancers, and estrogen for breast cancer, and so on. So these are not carcinogenic factors. These are just growth factors. And this is a case series that we presented at an ACE meeting some years ago, where we described 7 cases of aggressive papillary thyroid cancer in association with Graves' disease. And this is a picture that actually was published in our article, the review article, with Dr. Zahrani and Dr. Graziano. And actually, this is the first patient that I came across that really opened my eyes. And you see, this nodule was papillary cancer in a patient with severe Graves' disease, and all of these microcalcifications throughout the thyroid. These were microscopic and reasonably sized papillary cancer foci throughout the gland, and the patient had lymph node metastasis. So you could see the aggressiveness. And so I mentioned that during one of the meetings in Alexandria some years ago. You know, I was interviewed by جريدة اليوم السابع, and this is kind of like the title that الصحفية أستاذة أمل علام, she chose this. And so this is kind of like a public awareness. And there is a case report from Jordan, actually, that I came across in the literature, emphasizing the role, emphasizing the association between thyroid cancer and Graves' disease. So how do we manage Graves' disease? So if we look at Graves' disease, kind of like as a triangle, so we need to reduce the sympathetic outflow. We need to block the production and release of thyroid hormones, and we need to decrease the peripheral conversion of T4 to T3. These are the basic kind of like mechanisms of how we treat Graves' disease. So, so the medications that we use are the so-called thionamides, and in addition to the thionamides, so in this slide, the thionamides, are here. So both PTU and neomercazole or methimazole, they block new hormone release, and then new hormone production. And then there are some medications that block the hormone release, such as lithium and potassium iodide. Beta blockers here, as well as PTU and steroids, they block the T4 to T3 conversion. We don't use these anti-adrenergic agents anymore. And here, in severe cases such as thyroid storm, we can use plasmapheresis or charcoal hyperplasma perfusion to remove excessive thyroid hormones in thyroid crisis. And again, this is a nice depiction of where these major anti-thyroid hormones work inside the cells. And so just a word on the thionamides. So they interfere with with thyroid peroxidase catalyzed coupling, and they have inhibitory effect on thyroid follicular cell function and growth. And these are the main two medications. So propylthiouracil comes in 50 milligrams tablets, and PTU or carbimazole or numercazole, it comes in 5 or 10 milligram tablets. And typically the side effects are well known, and granulocytosis and the other side effects are well known, and we have to caution patients about them. And there is some years ago, the FDA issued a warning about PTU causing liver toxicity. There is also the notion that we should avoid methimazole or numercazole in early pregnancy or even before pregnancy in the first trimester and in the planning, because it can cause this acute aplastic defect in the scalp and skull. And the dosing, we start with a high dose and then we taper to maintenance. The duration is about 12 to 18 months. And of course, we can use much higher doses in storm or crisis of both medications. Now, the definitive treatment, a couple of words about that, is we resort to these definitive treatments, namely surgical or radioactive iodine ablation, typically if the medical therapy fails, or if there is severe side effects to medical therapy, medications, or if there is persistent thyrotoxicosis despite maximum antithyroid medication for a long time, or patient's preference. And of course, we have to remember eye disease and exophthalmos and thyroid eye disease, as well as smoking when it comes to radioactive iodine ablation, because there can be worsening of that. And we have to control hyperthyroidism before we give radioactive iodine. Otherwise, there will be a rebound and there will be an exacerbation of hyperthyroidism that can be serious and sometimes even life-threatening. So surgery, again, there are absolute indications as well as relative indications. And definitely in severe cases, one would opt for surgery because that's a rapid, removal of the gland that keeps making the thyroid hormones. But of course, we have to remember that T4 is it has a half-life of like 1 week, so you would need like 4 to 5 half-lives to level it down, and T3 has a half-life of 1 day. So we have to keep all of these in mind. My option, my preference, you may ask people about their preferences. I prefer to start with antithyroid medications, usually methimazole, unless the patients are pregnant, and I continue that for a year, like a year and a half to 2 years, and then see if there is a remission. We have a number of patients who were able to sustain remission and were able to take the medicine out, and so the patient will keep their thyroid, and you don't have to ablate or remove the gland. So we've been successful in managing patients with medical therapy rather than resorting to surgery or radioactive iodine treatment. But the 3 treatment modalities should be discussed with patient, and the patient preferences should be respected. And if we choose surgery or radioactive iodine treatment, as I have mentioned, we have to be careful about doing it safely. Hyperthyroidism should be controlled before radioactive iodine treatment. And in surgery, of course, if it is an emergency surgery, then we have to do that, but then there has to be coordination between anesthesia and maybe ICU and the surgeons and medical doctors, so that they keep the patient under monitoring and to avoid any deterioration. I think I have come to the end of my presentation. And again, I would like to thank the organizers for inviting me to speak in this prestigious symposium. And I think it's a great thing to have this organization of Arab Thyroid Association and to have this annual meeting. And again, I would like to thank everybody who has contributed to this presentation, and for those who I have collaborated with over the years, and for my teachers, late Dr. Dan Dewick and Dr. John Crockett. Thank you again. And I will be available for questions and answers. Thank you.
Thank you, Dr. Saleh, for your presentation. Thank you, Elizabeth. Thanks, everybody. It was really a fruitful presentation. I don't know if we still have time, because I think we exceeded the time of the session. But I will start with one or two questions that they were sent to me a few minutes ago from audience. For medical treatment of hyperthyroidism, is it better to give carbimazole dose in single shot or in divided times? Dr. Saleh, we don't hear you.
Yeah, sorry. Can you hear me now?
Yes.
I suppose that was a question for me, maybe.
Yeah.
Or I'm sure any of us can answer that. But yeah, I think you know, the tradition has been that propylthiouracil is more of a short-acting as compared to, well, in America we use methimazole, and I think elsewhere I think it's called numercazole. But when I looked up the literature, I'm not sure that they are very different, numercazole from methimazole, but the colleagues can correct me if I am wrong. So the tradition is that numercazole or methimazole are a little bit longer in duration. So once a day can work in these medications, at least in the case of methimazole. Maybe the colleagues in elsewhere outside America are more familiar with numercazole, but for methimazole, it can be used, and we use it as once a day, as compared, you know, to propylthiouracil, which is usually 2 to 3 times a day. However, in acute, or let's say in the crisis and severe cases, even methimazole, I use it like when I see a patient in the hospital burning with thyroid, especially if they have atrial fibrillation and whatnot, I would do like 20 milligrams 2 to 3 times a day of even methimazole. Or if you wish, 100 to 200 to 300 milligrams multiple times of propylthiouracil. I don't know if Dr. Priest and others agree with that.
Dr. Elizabeth?
Yeah, I don't have much to add.
Yeah. Okay, so again, what is the maximum dose of methimazole or numercaptozole or mercaptozole we can use in severe cases? You know, we have some cases with the resistant responding to lowering T3T4 and trying to increase the TSH. And we see in some cases we have a really resistance to medication, and some of colleagues, they keep increasing the dose up to 60 or 80 milligram, which I don't agree. So I think that in that case, as you said, we have to go to other emergency procedures. So what do you think about the dose? And
yeah, I agree. I just remember from a year or so ago, exactly like you mentioned, we had a patient who reached 90 milligrams of methimazole. But that was a patient who we couldn't either give radioiodine nor take to surgery at that time. We couldn't, because if I remember correctly, the patient had severe liver disease and was very sick. Surgery was very, very high risk. And of course, I wouldn't burn a thyroid with radioiodine in somebody who was so resistant. Finally, luckily, that patient, we were able to optimize his care, and he underwent surgical removal, and he was cured. But I don't think there is a limit to how much you can use if there is an indication, and it's the only thing. Like I mentioned, in acute or storm or crises. I mean, we may have reached 1,000 milligrams on more actually on PTU, and I don't know, like maybe 100 or so total of methimazole if needed. I mean, of course, there is always the risk of, you know, what we're trying to achieve, survival and, you know, health versus the side effects. So of course, you know, liver and granulocytosis are always important to consider.
Some tentatively tried to do a combination of proprietary seed and methimazole. Do you agree for such patients with resistance responding to therapy with mercaptazole alone?
Well, to be honest with you, I haven't heard of this. Maybe the colleagues have. I don't know. So, Dr. Peace, what do you think? I mean, they work on the same thing, so I don't know.
I can't see why there would be a benefit of using both. And then you're sort of potentially risking toxicities of two medications with nasty toxicities. So I think that's a bad idea.
Yeah. Ghada, do you have some questions?
Yes, I have a question for Professor Elizabeth about biotin. How many days we should stop biotin before reassessment of thyroid function test?
Probably 2 to 3 days is sufficient. And again, this is very assay specific, so it only matters if you happen to have an assay platform that's bioacylated.
Okay, do you have 2 minutes for the last question I just received about the triptomumab in treating patients with thyroid eye disease? So he's asking, what is the best time to start this medication?
Me or Elizabeth? Sorry?
I'll jump in. So basically, it's only available in the US right now. So that's the first thing, that if most of you probably on this call, it's not going to be an option. Okay. That may change going forward, of course. And it's a little bit debated whether steroids or teprotumumab are first line. The teprotumumab is probably more effective, but it's also much, much more expensive. And I think, you know, when to reach for one of these would be sort of dictated by the clinical activity score, you know, the severity. But anybody with moderate to severe disease, probably as soon as you can with one of those first line modalities.
Okay. Ghada?
I have a question for Professor Saleh about if the patient have positive TRAB only with normal thyroid function test and have exophthalmos. What about the treatment?
Yeah, well, that's a very good question. I assume that the patient does have a thyroid, right? Yeah. Or like, yeah.
Thyroid function only positive TRAB.
Oh, I see. Okay, because we have to keep in mind that those manifestations of engrave disease, the hyperthyroidism, the effect on the gland, and then the effects on the eyes and the skin are you know, two different things. As in the lecture about the thyroid eye disease that we heard a while ago, yeah, and the tryptoma, the Tepeza, tryptoma, you know, I cannot say the word, tryptomumab, they can come together, you know, but we have always learned that sometimes eye disease, even antecede or antedate or antecede the actual hyperthyroidism sometimes by many years, and even sometimes the eye disease can come later on. So the positive antibodies, it's interesting that sometimes even if you, in the world of diabetes, we have a lot of patients who have GAD antibodies, but they don't have diabetes. We do have patients who have, the TSI or TRAP positive, but they don't have active disease. I don't know in this case if the test is correct and there is an antibody. Is it just a small titer that is not really stimulating the thyroid, so the thyroid numbers are normal, or is it a lab error? Just to add to the biotin thing, as Dr. Pierce mentioned, and I happen to have done a lot of work on biotin and disclosure. I consult for Abbott, and is that actually TSI and TRAP can also be high in biotin. So you have a perfect case of Graves' disease in biotin. So I don't know exactly what to do here. I mean, if the thyroid is normal, I mean the numbers, like the patient's euthyroid, and really euthyroid, not lab error. So the patient's euthyroid, there is no active eye disease and a positive antibody. I think I would observe these cases until we have a medication that will block the effect of TSI, and it's coming. I'm hearing there are some products, like some work in the pipeline to address that. But I don't know, Dr. Pierce, if you agree. I mean, if it is just the antibody but nothing else, and we have to be careful maybe about possibility of thyroid nodule being more aggressive if there is TSI or TRAP positive. But if there is no eye or skin or thyroid disease, I think I would monitor maybe.
And do the same. And I just make sure that the patient was aware of symptoms of thyroid dysfunction to watch for.
Correct.
I think we are, I don't know if we can add anything. We are out of time. Thank you, everybody. Ghada, do you want to add anything else for the? Okay. Thank you very much for your participation, cooperation, and the fruity lecture that we learned a lot today, as we always learn more and more. Thank you very much.
My pleasure.
Thank you all. And it's a pleasure meeting all of you. Bye-bye.